So maybe in the interest of time, we kick off, and I'm sure more people will join soon. And thank you for everybody that's come here today at 12 o'clock. So my name's Abhijit Gill. Most of you have met me before. So I'm the GP. I work in Hammersmith and Fulham, and I'm the North West London Primary Care Cancer Clinical Director for RM Partners. We are very lucky today because we are joined by our two specialist colleagues. We've got Dr. Anastasia Chu, who's a haematology consultant from Chelsea and Westminster NHS Foundation Trust, and Dr. Cll the who's a consultant haematologist working at the Hillingdon Hospital NHS Foundation Trust. Thank you so much for your time, and thank you so much for bringing your expertise here today, and we've got a lot to learn from you both. So just a bit of housekeeping rules for me, really. Could please everybody, when we are having the presentations, keep yourself on mute and keep your video off as well, just to save on our bandwidth. And we'll be using the chat function as the main way to ask questions, and we've structured our discussion and presentation today through a series of cases, which will be really interesting. So if there's any questions that come up, please raise your hand or use the chat box, in which we will be monitoring constantly. We will be recording the webinar as we have done in the past, and we will circulate it through the training hubs and through our usual primary care communications team, and so that people that couldn't quite make it today on time can see our webinar and go through things at their own leisure. So please feel free to ask questions, make comments throughout the webinar. We want to keep things interactive, and your challenges will be greatly received. We will also be sending out an evaluation link at the end of the webinar, and we'll put the link within the chat box as well, so that everybody has that, and your feedback is very much appreciated. So we've got the agenda here up on the screen today. As you can see, we are focusing on haematological malignancies, a little bit from me, but vast majority coming through with our specialists, because they're the people that you want to hear from. Okay, so if we could get onto the next slide, please. Thank you. So as we said, we're focusing on haematological malignancies, and we're bringing this here today through feedback from our primary care colleagues who want to know a little bit more about how we can improve our referrals into hospitals and through our 2-week waits. And we know that it's a common malignancy within the UK, and around about 250,000 people are living in the UK with blood cancer. And it's interesting, really, that the within the UK and particularly within London, a lot of patients that come in are diagnosed with haematological malignancies are not always diagnosed through the 2-week rule. We have patients that are diagnosed via routine referrals or even emergency presentations within A&E and the emergency department, and also more recently through non-site specific RDCs. And so it's quite important that we consider, and the aim of this webinar session is to support the detection of haematological malignancies earlier within primary care, but also considering what is most appropriate to go down these 2-week wait pathways, and how can we get these patients seeing the specialists at an earlier stage. And we'll be doing this through interactive case studies, discussions, and through sharing information about forms, etc. And so before I hand over to Anastasia and Cll for their expertise, I just wanted to share some Northwest London specific data. So this particular slide really just looks at the first seen 2-week wait patients, and the latest data available confirms that in October, about 115 patients were referred under a 2-week wait were seen within 2 weeks. Here we can really see that the numbers of patients that were referred on the 2-week wait pathway before and during the pandemic has remained relatively stable, which is interesting. And on the next slide, really reflects that more often than not, haematological malignancies are diagnosed via the 2-week wait pathway through other different routes. And you can see that really here on the breakdown. With April 21 to October 21, we had 33% through a 2-week wait rule, and 67% came through other routes. And so that's something that I really want us to remember and consider. Just a little bit more data here. What we're looking at here is that the graph demonstrates a number of patients accessing first treatments in comparison to last year and the year before, and really that's remained relatively stable, and no breaches in performances from the trust that we can see on the next few slides as well. Here we go. Excellent. Thank you very much. And so what I will do now is that I'm going to hand over to Anastasia and Akila, and will take us through the next part of the presentation.
Hi, good afternoon, everyone. Thank you very much for sparing your lunch hour to listen to or be. Let's seek some clarification about referring into haematology, especially given queries regarding cancer. So I'm Dr. Akila Danga, one of the consultant haematologists at Hillingdon. Thank you, Abs. And Anastasia and I will be sort of sharing the next 50 minutes or so, going through the actual cancer referral pathway, and we want to try and make it quite an interactive session so that you feel that you've got the most out of it and have the opportunity to ask questions. So please feel free to either put your hand up or post in the chat. So firstly, I just want to sort of orientate yourselves around the suspected hematological cancer form. So the front page of the form, it has suspected hematological cancer at the top, and then you've got the next box, which is your cancer type that's suspected, either leukemia, lymphoma, or myeloma, based on upon the patient that's been seen, their clinical review or blood tests. At the top there, you've got two boxes, one that would bypass 2-week wait, i.e. you're so worried they should go straight to accident and emergency, and these include any young children or young people with unexplained hepatosplenomegaly or lymphadenopathy or petechiae, a blood film that suggests acute leukemia, and Anastasia will speak more about this, any signs or symptoms suggestive of cord compression, acute renal failure, and platelets less than 20. These patients should bypass any referral and should go straight to A&E. Then you have others which you would we would recommend are seen within 48 hours, and these are with those with unexplained bruising, those over the age of 40 with more than 6 weeks of bone pain, over the age of 40 with unexplained fracture, and those over the age of 40 with back pain and red flag symptoms. These, can we just move it along a bit? So with those, so you've got two separate criteria that need to be in place alongside these symptoms with this second box. So with the unexplained bruising, it would be important to have a full blood count, clotting profile, using hematinics done, and with or without those subsequent bottom two. And those with other symptoms, it's important also to have baseline screening blood tests done as well. Some patients, I think you as clinicians can also exert sort of a sixth sense in terms of when you see a patient and you think this patient's really unwell, they need to be seen by somebody straight away, i.e. do they need to go into A&E? That's a clinical decision to make, or alternatively get on the phone and speak to one of us, or you can do, if we do the next slide, an urgent advice and guidance via the 2-week wait pathway. So this is a new box that has been put into the revised referral form that came out, I want to say late last year, but the revised form has now got a new box at the bottom which asks for urgent advice and guidance from hemato-oncology. So it's not necessarily you saying, I think this patient needs to be seen in clinic on a 2-week wait, but I would like some urgent advice. Do you think the patient needs to be seen, or do I need to do anything more? And with that, you would get a response back on the day the referral was received by the clinician. And following on from that, it's also incredibly important that we can contact you. So often we get a bypass number, the main reception number for the GP. What is very useful is potentially having an email address of somebody who would be able to check the responses if somebody chose to email, but alternatively a direct number, especially if you're doing advice and guidance or seeking urgent advice, for us to be able to pick up the phone and speak to you directly would be very beneficial. And with that, I'm going to hand over to Anastasia, who's going to go through the next section on the cancer pathway referral form to do with abnormal blood results.
Right, hello, thank you. Yes, I'm Anastasia. I work at West Mid as part of the Chelsea Trust. So first of all, I've got a couple of cases which, as everyone has said, are interactive. So this is a patient. If you just have I want to give everyone a little bit of time to have a look at the blood results. So this was a 42-year-old dentist who'd had some bruising, had bloods done by the GP. These are the results. And then I'd just like to get, I'm hoping this is an anonymous poll, just to let me know what you would do. So main thing is HB 73, white cells 4.8, platelets 41, neutrophils 1.9. So if you would just like to vote on what you think should be done in this situation. Right, I've got 8 responses, so that's probably everyone here. So this is a really abnormal full blood count. I'd be worried. It's a young patient. She's got symptoms. So yeah, sorry, go on to the next slide, Sophie. So on here, you've got a highly abnormal full blood count. And Sophie, is there another box that comes up on this one? So when we look at the criteria here, we don't have a blood film report for this patient, but we do have the second point there, out of range blood counts in more than one line. So she's very anemic and also thrombocytopenic. If we ignore this case and just have a look at the other counts though, when we're talking about a highly abnormal full blood count, it's generally more than one cell line or quite an abnormal count. So platelets of 146 doesn't count as a highly abnormal full blood count result. Okay, so we're looking at quite marked thrombocytopenia or thrombocytosis. But coming back to this lady, highly abnormal. She's also got unexplained bruising that I know from the referral. And so for this case, although there is the 2-week wait option available, actually I would prefer, as most of you have said, that this is an urgent call to haematology and referral. This was, sorry, next slide. So she's got a bicytopenia. She's also got a marked macrocytosis. She's young. She urgently needs to be seen and a review. And especially if she had previous results which were normal. So this is acute onset. This is concerning. Please do send it in. And she was 42 and she had high risk myelodysplasia and has actually gone for a stem cell transplant. Okay, so the next abnormal full blood count. So these are all genuine cases that I've had. So this is a 2-week wait referral. I had no clinical details on a 66-year-old lady, and this was ticked as highly abnormal blood count. So headlines here: hemoglobin 142, white cells 13, neutrophilia 9.5, with a mildly elevated hematocrit 0.48. and platelets 359. So again, can we have a poll on what to do with this one? Oh, sorry, no, we don't have a poll. Right, ignore me then. So on this one, yes, technically the results are out of range. However, they are really mild abnormalities, okay? If you are concerned about this patient, again, give us the clinical details, okay? Are they on steroids? That will give you a neutrophilia. Were they clinically unwell? Do they have an infection? That will give you a neutrophilia. Okay, so for these really mild abnormalities, in the first instance, consider repeating them. And if you are concerned, please do use advice and guidance, okay? But this should not be coming through as a 2-week wait referral. Okay, next one. Erythrocytosis is really common. Please be aware that there are these Northwest London pathways, which are really nice. They're all flow diagrams and they're available, and we will give you the link to them if you don't already have it. But for all of, for a lot of these conditions, we're looking at persistent changes. Okay, so unlike the first lady where it was a really acute, very abnormal, for these milder abnormalities, it does have to be persistent, so more than 2 months apart. When we're looking at erythrocytosis, consider whether they are well hydrated. If they've just had diarrhea and vomiting, it's not going to be a myeloproliferative disorder. And remember secondary causes for erythrocytosis. Over 80% of patients, I'd say, that we see in clinic with erythrocytosis, it's a secondary cause. So they've got severe COPD or other issues going on. But there's nice criteria there which are very clear of when to refer, and generally these patients are not a 2-week wait referral because myeloproliferative disorders do not count as an actual cancer. They're pre-malignant conditions. If you are worried and someone does have symptoms of polycythemia, so they're they've got blurred vision, they're feeling a bit lightheaded, then that should come into A&E because they will need an urgent venous section. Okay. Okay, next slide. So this is my sort of bottom line. Too much of normal things are generally unlikely to be a cancer. So myeloproliferative disorders, where you're seeing high either red cells or platelets, aren't classified as a cancer. We will see them soon, but please don't send them as a 2-week wait. Other things, so you know the causes of a lymphocytosis can be smoking reactive to a recent viral infection, again, neutrophilia, infective smoking, steroids, long-term steroids, and eosinophilia. Please do consider first whether they've been traveling, whether they've picked up a worm, or whether they've got asthma or really bad eczema. If you are concerned for all these things, please do come through to advice and guidance. So too few of normal things. Please, please do check hematinics, okay? It's the most common cause for low anything. If it's the other things, though, that are more concerning are an unwell patient with bone marrow suppression. Alcohol, always consider alcohol as a cause for suppressing bone marrow, and infiltration, so things like leukemia and metastatic disease, are going to be far less common than things like hematinics. Okay, next slide. Another really common referral. So the important thing to remember with platelets is that most people don't get bleeding with platelets until the count is well under 50. And even then, we see patients with single-figure platelets who don't bleed. There are a huge number of non-hematological causes for thrombocytopenia, hematinics, viral infections, hepatitis, Helicobacter pylori is not on that list, but probably should be, which is easily tested for and treated. So you will refer patients to us and we will reject them, and you'll get grumpy with us because they've got platelet counts over 100. But the reason is that generally it doesn't cause an issue with a platelet count over 100. And also the treatment for thrombocytopenia tends to be relatively toxic and it's often long-term steroids or other immunosuppression, and will cause far more problems than it solves in a patient who is well and not bleeding. So again, the pathways state only refer if platelets are less than 50 or between 50 and 100 with other issues that are concerning, such as splenomegaly, lymphadenopathy, or they're pregnant, or they are having active bleeding. And then, as I will reiterate, bleeding with a platelet count over 50 is very unusual. Okay, next slide. So bottom line, abnormalities affecting more than one cell type are more likely to be due to bone marrow causes rather than reactive. And any comment, so if people are worried about missing the really abnormal full blood counts, they will usually 99% of the time be flagged by the lab and we'll know about them before you. So there is that backup system as well. Okay, this is my last bit for now. We get a huge number of referrals with high B12. A high B12 in itself isn't harmful. Common causes are multivitamins, not specifically B12, but just multivitamins, or they're vegan and they've got a diet high in soya or yeast supplements. Myeloproliferative disorders is one cause, but you would have an abnormal full blood count. So if you've got a patient with a high B12 but a normal full blood count, it's not going to be a myeloproliferative disorder. The other causes to look at are renal and liver disease, autoimmune disease. But in itself, it's not harmful. I wouldn't recommend repeat testing unless there's a clinical indication, and we don't need to see these patients. Okay, next slide. Has anyone got any questions or comments just about the full blood count before we move on? Go on.
I might just come in, Anastasia. Thank you for that. It's really, really helpful. And just coming on to the B12, so sometimes we've started to see patients referred by GPs to the non-site specific RDCs to say high B12 may mean other cancers, not just hematological. And I wonder, and sometimes we've had hematology colleagues referring back to the GP say, this may be a solid tumour. I don't think it's hematological. Please refer on to acute oncology. And do you have any take on that at all?
Yeah, we don't, unless there's actually other symptoms to suggest another site, or there's other concerning symptoms like weight loss, unintended weight loss, then it's a bit of a fishing expedition, and I don't want to overload the acute oncology diagnostic service either. So by itself, unconcerned, but you've all got clinical acumen. If you are concerned about the patient for other reasons, you've examined them, there's something obvious, then I would refer on.
Thank you, really helpful.
And I think just coming in there, just following on from what Anastasia said, the other thing is B12 and the liver. So in terms of thinking about abnormal liver function tests or a liver ultrasound scan, in terms of simple things to begin with, if we've exhausted, so hematologically we're not concerned, because the most common other malignancies is typically associated with hepatocellular or liver malignancy. So yeah, I echo what Anastasia said, that it's difficult then to just say for us, if I asked every raised B12 to be referred to the CUP services, it would inundate the service, but also I think a lot of the time it is just you're chasing your tails and you'll never find a cause, and the anxiety then that causes in the patient is extreme.
Okay, so moving on, we've got two different patients with the same disease here. So first of all, a 57-year-old man, routine bloods done because he's diabetic and hypertensive. You'll all be familiar with this. He is clinically well, and that's his full blood count. So hemoglobin 156, white cells 10.2, neutrophils 4.3, lymphocytes 6.7, platelets 280. So again, if we can pop the poll up, how much, what would you go for on this patient? So this is patient 1. Anyone else? Okay, so we've got 5 responses, so I'm very glad that you're all being very sensible. So for this patient, I absolutely agree, repeat the bloods. We do get a lot of referrals with the lymphocytosis of 4.2. And as we were saying before, it's a very mild abnormality. If we go on to the next slide. Right, this is patient 2. Sorry, go back one more. No, patient 2. So, different patient. You've got your same options. Although for some reason it's one option. But again, if you would like to, Sophie, can we have another poll? What you would do for this lady? So, 78-year-old, 8 kilograms documented weight loss. So she's come into your surgery and you have measured that she has lost weight, and she's complaining of generalized fatigue. This time hemoglobin 102, white cells 56, neutrophils 4.3, lymphocytes 52, and platelets 115. So in this scenario, what would you do? Okay, I think we've got everyone. So it's either refer as a 2-week wait, routine referral, and a blood film. Okay, so if we go on to the next slide. So this, sorry, skip that one as well. Okay, so for patient 1, we mostly went with repeat the bloods, and 4 weeks is probably a bit soon. I'd probably go with a little bit longer. He's got persistent low-grade lymphocytosis, but no hepatosplenomegaly, no lymphadenopathy, and no B symptoms. So if we go on to the next slide. So just to, I know you know this, but just to reiterate, B symptoms, there's really clear definitions of B symptoms. And often when we ask patients, they've been referred as night sweats. But when you actually ask, they're not drenching. So you really need to be saying, are you having to get up in the middle of the night and change your pajamas? When we say fevers, it's not just that they felt a bit hot, that they actually checked their temperatures. Because often when you say, have you had a fever? They say, oh yes, and I checked my temperature and it was 37.2. So it's that perception of what the patient actually thinks is a fever, and it's a loss of 10% body weight. Obviously, this is difficult. A lot of people don't have a documented weight, but things like I've gone down a dress size is a useful marker for that. Okay, next slide. So for CLL, the diagnostic criteria does say that you have to have a persistent lymphocytosis over 5. So as we said with the full blood counts, if you've got a slight abnormality, I'm generally not worried. So it is over 5. So lymphocyte counts are 4.6, fine, you don't need to do anything. It needs to be sustained for over 3 months. So we're not interested if it's only been there for a couple of weeks. There is another condition which is related, which is called monoclonal B-cell lymphocytosis, but I often think it's not very helpful to diagnose patients with these pre-malignant conditions, just because it's a lot of anxiety and we're not going to do anything about it. Okay, so next slide. Hematologists are awful at acronyms, and the diseases are all slightly different but not different, so same but different. Small lymphocytic leukemia is the same disease as CLL, but you don't get the lymphocytosis. It's more of a lymphoma presentation, so they just get the lymph nodes and hepatosplenomegaly, but it's essentially the same disease. But you might see that is the explanation for it. It's exactly the same disease essentially, but no leukemic aspect. Okay, so for the next slide, and this is really just to remind you that when we're talking about CLL, you're looking at your B lymphocytes. So it's very late in the day, like our patient 2, where you're getting falls in the myeloid system. Okay, so if you've got the myeloid system being affected, then that means you have got a lot of disease in the bone marrow, and that is where the activity is going on. The lymphocytes are taking over. Okay, so next slide. So go back to patient 1. You've examined him. He hasn't got any lymphadenopathy or hepatosplenomegaly. He's not got any anemia or thrombocytopenia. So he's an early stage CLL. If we remember patient 2, so she is anemic and she's also got thrombocytopenia, and we don't know about lymphadenopathy, we've not examined her yet, but she's already falling into a much more advanced stage. So this is, you've all picked up on that, that's why you've all said 2-week wait referral, which is the correct thing to do. Someone said routine referral of to hematology. I think actually in this case I would go with either. I don't think it's urgent that we see her within 2 weeks because CLL is still a chronic slow disease, but I wouldn't reject either referral. Someone's just put, if we have a few lymph nodes with a normal full blood count, can we reassure them? So I would still, if they have lymph nodes, I would reassure, I would send them in, because you don't know what that lymph node is. It might not even be a lymph node. The only way to know is to do an ultrasound. So I think if someone does have a lymph node, I would still send them. So next slide, and this is really just to show you. So this patient 1, this first patient, we can be really reassured. We don't need to rush into anything. His overall survival at 5 years is 93%, and a lot of the people who will have died from something else, because this is a disease of the elderly. And we're not going to treat him, but what we are going to do is give him a label to say you've got leukemia, and we're not going to do anything about it, which a lot of people find very difficult. But obviously when you're looking at the second patient, she's going to fall into a higher risk category because she's a higher stage, and so she does need treatment. Okay, next slide. And this is, we disagree on this, but you will know your patients better, but in patients who have a very low level of lymphocytosis with no lymphadenopathy and who are otherwise well with no cytopenias, do just think, is it helpful to diagnose them with a potential leukemia? It's a psychological impact, but also they then find it difficult to get life insurance, travel insurance in future. Obviously, there are some patients who would always want to know, but that's just I think I would probably rather not know, especially if I was in my early 50s. Okay, next slide. So you have access to the guidelines, and this is just to emphasize that for 70% of patients, the diagnosis of CLL is an incidental finding. And if they are asymptomatic, so no B symptoms, no anemia or thrombocytopenia, it should not be a 2-week wait referral. Okay, next slide. Right, is there anything else on CLL or that kind of scenario that anyone has any questions for?
Anastasia, that's really helpful actually, because it helps break it down in a really nice way about the different types of CLL that may come through through a couple of cases. Do you mind if I just ask? So you imagine that the first chap that we had, and we have an open conversation to say, look, this might be, it's not really of much significance. Hematology are not going to do much here, even if we have a diagnosis. Would it be prudent or worth us in general practice thinking about annual full blood counts, or is it something that we should just forget about and leave?
Yeah, no, I would. Again, it's difficult here. It depends on the conversation you're having with the patient. I think an annual full blood count, most of these patients will be having annual full blood counts anyway for other reasons. And I think probably not to make a big song and dance about it and say, yes, we'd repeat full blood count in a year just to have a look at your lymphocyte count. But obviously, you know, if things happen in the meantime, they become symptomatic, then they'll need one sooner.
Awesome, thank you.
Okay, I'm going to hand over to Akila.
Right, a topic of interest to everyone in secondary care and primary care, paraproteins and light chains. So I will take a little bit of time just orientating all of you regarding how to interpret the results. But firstly, this is how it looks on the cancer pathway referral form. It has become more explicit in terms of which criteria they have to meet in order to be able to be referred on a 2-week wait. Otherwise, it would be an advice and guidance, routine or urgent referral. And that's because we were seeing way too many MGUSs being referred to us, or light chains of insignificant values referred as a cancer pathway. So this is across London, it was agreed that these criteria are essential to be met, seen on the cancer pathway. So a monoclonal paraprotein on serum protein electrophoresis, so monoclonal is key there, more than 10. A raised serum-free light chain with a ratio, so that's not the actual number, the actual ratio where they look at the Kappa and the Lambda, I'll talk more about this in just a moment, of more than 5 or less than 0.1. Urine Bence-Jones protein suggestive of myeloma, so that's coupled with other findings, and a paraprotein of any level in the presence of significant red flag symptoms. So, for example, crab features. With that, you're looking at hypercalcemia, renal impairment, anemia, and bone disease. Now, I will just ask you to exert your common sense with this as well. So if a patient's known to have a hemoglobin of 100 and it goes to 99, that's not a significant anemia in the presence of that paraprotein. We're looking at a drop, and I'll talk more about this, of more than 20 grams from their baseline. And it's also important to realize that ALP rises are not typical of myeloma. So all too often we say this patient's got bone pain, they've got a raised ALP, they've got myeloma, and we get a 2-week wait referral. So they don't go hand in hand. The Bence-Jones protein looks at the total urinary protein as well as Bence-Jones protein. So sometimes the fine print will tell you that there's no Bence-Jones proteins, but proteins have been picked up, and then this triggers a 2-week wait referral as well. And serum-free light chains, so SFLC is short for serum-free light chains, can be raised in renal impairment, and that's when looking at the ratios really important and not the absolute number. So if we can have the next slide, please. So this is a normal result. So I've just picked up a random patient from ICE. So this is how, when you, as primary care physicians, request a myeloma screen, request an immunoglobulin, serum protein electrophoresis or immunofixation or serum-free light chains, this is how they are reported. And I'm just going to go through a normal result to begin with. So you get the absolute quantity of your immunoglobulin, so IgA, IgG and IgM, that's your normal range on this end here, and this is how much the patient has. So this is all normal. They then take these and do a serum protein electrophoresis on it to look to see as to whether there are identical copies of immunoglobulins or whether it's a soup of immunoglobulins. So are they monoclonal or are they polyclonal? This person has got a normal immunofixation, so there's not a polyclonal paraprotein or increase, and there's not a monoclonal paraprotein or increase. And it has been reported as no paraprotein detected on immunofixation. So that's important here. So there's no paraprotein, no clonality, suggesting there's a population of clone or plasma cells, cancer cells making that protein. And then you've got your light chains here. So you've got your Kappa light chains and your Lambda light chains. So this is where it's really important to look at the ratio. So whilst the absolute number may be raised, if the ratio is still within the normal range, we're really not interested, unless, of course, they've got a really big paraprotein as well, because sometimes people can have a paraprotein and the light chains can be normal. Alternatively, the light chains can be really abnormal and they can have no paraprotein. So it's important to look at all of the results in combination with each other. Can I have the next slide, please? So now I'm going to go into some case studies. I'm going to go through it piecemeal, so you have time to sort of think about what your responses would be when we come to the polls. So these are all my cases are also those that I've vetted on a 2-week wait pathway. So they're all those who've been received on a suspected cancer pathway. So first was a gentleman, 69 years old, a retired engineer who saw his GP complaining of back pain. Of note, on the 2-week wait referral form, I could see from the historic entries that he's had a long-standing history of back pain and he wasn't responding to simple analgesia. GP was kind enough to inform me that there were no red flag symptoms associated with the back pain. Patient hadn't complained of any B symptoms, so weight loss, night sweats or fever, the ones that Anastasia mentioned earlier. And the GP then requests blood films, including a myeloma screen, a CRP, an ESR and rheumatoid factor. Can I have the next slide, please? So these were his results. So initially you have your immunoglobulin. So the IgA was normal, the IgG was normal, and the IgM was elevated at 2.23, with the normal range being between 0.5 and 2. On immunofixation here, it tells you to look at the electrophoresis report below. So the protein electrophoresis report is there, and I'm just going to read it out. Serum immunofixation, 2 paraproteins, types IgG lambda and IgM kappa are detected in the gamma region. In terms of quantification, so how big they are, it says here that IgG lambda paraprotein has a concentration no greater than 3 grams per litre, and the IgM kappa paraprotein has a concentration that is too low to quantify. They've also done the light chains, which show that the Kappa light chains are slightly elevated from the upper limit of normal, so they're 25.9, with the upper limit of normal being 19.4, and the ratio is entirely normal. And I haven't put it on here just to reduce the number of slides. Hemoglobin was completely normal, so the patient's not anemic. The adjusted calcium is normal. The urinary Bence-Jones proteins were reported as not detected, and the creatinine was at the patient's baseline at 111 micromoles per litre. So if you just take a snapshot of that in your mind, and then I'll move on to the X-ray findings. So if you remember, the patient has got a history of long-standing back pain, so a thoracolumbar spinal X-ray was requested, and it just shows degenerative change. Yeah. So if we can move on to the next slide, please. So if you would then now like to take a minute to vote, so about what you would do next. So the options are referring on a cancer pathway, that's A. Option B is request urgently to be seen by hematology. Option C, or the third option, is request routinely to be seen by hematology. The fourth option is to seek hematology advice and guidance. And the last option, option 5, is to reassure the patient. And the last option, which I'm hoping none of you will pick, is to do nothing. So I'll just give you a couple of minutes to sort of think about what you, a minute or so to think about what you do, and then we can discuss the outcome. This is all anonymous, so I do encourage everyone to partake in the polling. Okay, so that's very interesting. So of the 11 responses, we've had 8 say that they would seek advice and guidance, and 4 say they would reassure the patient and monitor in primary care, which pleases me, but let's go on to the next slide. Okay, so this patient was actually referred on the cancer pathway. Although they were referred, they were not seen on the cancer pathway because I downgraded the referral and informed the GP of the outcome accordingly. And they were seen routinely in the haematology outpatient clinic. The bloods were all in keeping with MGUS, which is a monoclonal gammopathy of undetermined significance. So what that basically means is we've picked up a clone of plasma cells, which are being measured in the form of a paraprotein, so clonal immunoglobulins, but the paraprotein was 3 grams per litre. With that, you had no Crab features, no immune paresis, so none of the other immunoglobulins were low, and there was no reproducible back pain. So the back pain wasn't out with keeping of knowing a patient's got chronic back pain with degenerative change. We saw the patient as a one-off and discharged him back to primary care with the advice of annual monitoring and clear advice regarding referral criteria. And it was quite refreshing to see that 4 patients would reassure the patient and 4 GPs would reassure the patient and monitor in primary care, because a lot of us are now replying to advice and guidance with this advice. Actually, from everything you've done, this sounds very much like an MGUS. It is at the moment just a label, it's not a cancer, and we would simply advise annual monitoring with the paraprotein, looking for any evidence of end organ damage or Crab features, or any pain which is significantly out with keeping the patient's usual pain. So that's how we're now moving towards managing these patients, because being seen every 3 months in clinic in haematology won't add anything in terms of their management. And the other thing is, I think when thinking about referring people on a cancer referral pathway, it's a significant thing to do for that patient, especially if from the blood test right from the start we can say this isn't a cancer, please don't plant that seed. The number of times we see patients who we simply choose to reassure and discharge on a cancer referral pathway on their first meet. And it's very hard for us to reassure these patients without undertaking whole body scans and various other things, because they're fixated in their heads as something more serious going on. So I think if we start off with the right footing on these patients, it's better. And if you're not sure, we'd rather be asked on advice and guidance. Next slide, please. So before I move on to the next case, are there any questions? Okay, so there's a theme that's going to come out of this. I think there's 3 just based around immunoglobulins and how to interpret results. So the next case is an 87-year-old female, and routine bloods were showing a decline in their renal function. Creatinine went from 75 to 92 millimoles per litre, and the EGFR had also gone down. There were no other untoward symptoms to report. So these were just routine blood tests being done in primary care for other things like diabetes or thyroid checking, I'm not sure. And patient didn't have any other B symptoms, so the GP then requested additional bloods, including a myeloma screen, to look for causes of the renal deterioration. Next slide, please. Sorry if this doesn't project very well, but just to highlight here, you've got a elevated IgA at 4.17. The upper limit of the range of normal is 4. Protein electrophoresis, no paraprotein detected on electrophoresis. Creatinine is 90. Kappa light chains are 31.6, so above the upper limit of normal. Lambda light chains are also elevated at 27.3, so just above the upper limit of normal. Ratio is 1.16. Hemoglobin is normal, adjusted calcium is normal. Creatinine, as you know, is about 90. Very elevated ESR at 87 millimeters per hour, and the urinary Bence-Jones proteins were not detected. So with that in mind, if we can go on to the next poll, please. So what would you do? The options are in the same order as the previous case. I have 5 responses. Are there any more that are going to trickle in?
This is all anonymous, everyone. Please do.
Really is anonymous, so there's no judgment at all. And actually, we're just using this as a platform to try and sort of clarify things, because I appreciate the nuances with interpreting this can be a little bit difficult, but I'm hoping you'll go away feeling a bit more confident in how to interpret these results. Okay, so we have one person who would refer as a cancer pathway, one who would do a routine hematology outpatient review, one who would seek advice, and 4 who would seek advice and guidance, and 1 who would reassure the patient and monitor in primary care. Okay, so if we move on to the next slide, please. So the patient was referred as a suspected cancer. I not only downgraded the referral, but felt the patient did not need to be seen in haematology at all, and the primary referral was informed. Now, we always do a letter detailing why we're going to either reject or downgrade 2E grade referrals, but the primary reason for this case was on the immunoglobulins, no paraprotein was identified, so there's no suggestion of a clonal disorder there. Although the Kappa and Lambda light chains were both elevated, the ratio was entirely normal. Serum-free light chains leak through kidneys for other pathologies as well, for example, renal impairment. So alternate pathologies need to be sought with regards to this patient's kidney function and why it's deteriorating, because there's been no demonstration that there is a clone of plasma cells that is causing the outcome here. And that's important. Now, if you're not sure, ask. So you can send a REGO advice and guidance with this, and we will just whip you off a one-liner saying ratio is normal, nothing to worry about, seek alternate causes for the renal deterioration. Next case, please. Thank you. So the last in this theme was a 48-year-old gentleman who had a telephone consultation with the GP for non-specific symptoms, so lethargy, shortness of breath on exertion, weight loss but had puffy feet and complained of frothy urine. So the GP requested some bloods, including a full blood count, renal profile, a troponin, a BNP, CRP, ESR, hematinics and a myeloma screen. Next slide, please. And these were your results. So here you've got a hemoglobin of 112 grams per litre. Of note, on historic results, patient was never anemic. Adjusted calcium was normal. Sorry, I haven't put the result there. Creatinine was 924 micromoles per litre. ESR was 83 millimeters per hour. Urine bench Jones proteins was still pending. BNP was 946 nanograms per litre, and the troponin was elevated at 75. You've got really abnormal looking myeloma screen here. So you've got an elevated IgG, which is just above the upper limit of normal, an increased IgA and a low IgM. Protein electrophoresis shows increased gamma globulin in the beta gamma fusion, consistent with an increased IgA. This pattern results may be found in association with liver disease, intestinal or respiratory infections, or rheumatoid arthritis. No paraprotein detected on electrophoresis. Total protein is elevated. Kappa light chains are 202, Lambda light chains 156, and the ratio is normal. So if you just take a moment to take that in, and we can go to the poll in terms of how you would action this next. So we've had 7 responses so far. A few more coming in. So we've got 3 who are saying they would refer to haematology on a suspected haematological cancer pathway, 3 who would seek advice and guidance, and 2 who would reassure the patient and monitor. So if we can just move on to the next slide, please. So it was referred as a suspected cancer. The referral was not only downgraded, but also rejected. So we didn't think the patient needed to be seen in haematology at all. And the primary referral was informed and the letter was done. And in the letter, we advised urgent referral to renal physicians, if not already done so. It transpired when I spoke to the GP that the patient had already got established end-stage renal failure and was on renal replacement therapy, which would account for the really abnormal creatinine and at Hammersmith Hospital. but also would account for the abnormal light chains, so the elevated Kappa light chains, elevated Lambda light chains, but with a normal ratio. End-stage renal failure will also cause a degree of anemia because erythropoietin is produced by the kidney, so that can cause a degree of anemia, and the elevated ESR can go in. The differentials for an elevated ESR are incredibly wide. So if you can't demonstrate a clonal disorder in the presence of a paraprotein or elevated light chains with an abnormal ratio in conjunction with an ESR, you can't call it a hematological condition that's driving that elevated ESR. It's the bane of our lives a little bit with regards to this ESR's up. What should we do with it? Anything can really cause it. Infection, inflammation, other conditions in terms of your systems review, and all of this would need to be reviewed again. I've just got somebody who's said something in the chat. I was not aware secondary care colleagues could downgrade cancer ERS referrals. Who's responsible? So this is actually very interesting. So yes, we as secondary care can downgrade referrals, which is why it's so important that we have contact details for the person who's making that referral. It is a little bit frustrating when we call the practice back and they say the GP who made the referral is not here till next week, and often then we speak to the duty doctor. But the basis of then the responsibility is for the initial person who made the referral to inform the patient. So if you've made the referral on a cancer pathway, we think the patient does not need to be seen within 2 weeks on a cancer pathway. It is your responsibility to inform the patient accordingly. If we then say we'll see the patient either urgently or routinely, a letter and an appointment will follow, a letter to yourselves explaining why, and an appointment to the patient. If we think the patient doesn't need to be seen at all, we won't book them into a clinic.
Can I just add to that, that if we see a patient, so for example, a CLL that we think, as we discussed before, needs to be seen but isn't a 2-week wait, I have to just reject that outright, because I'm not allowed to then rebook it as a routine, because the cancer clock has started and the managers don't like it. Okay, so it seems very pernickety. I will ask you to re-refer. It's not me being difficult, it's the system. But we just can't see every single 2-week wait referral. I think we reject about 60%. And it means that then the actual patients who do need seeing, who genuinely do have cancer, won't get in.
And I think just following, so just reading the rest of that, it's just regarding how you then reassure the patient that they don't have a cancer or they don't need to be seen. I think it comes back to the fact of, if you're not sure whether they need to be seen on a 2-week wait, ask us first. So don't initiate the 2-week wait in the first place. That's the difficulty we then have as clinicians in secondary care, to try and reassure a patient that they don't need a CT body, they don't need an MRI, and they don't need a bone marrow biopsy. Because if it's not indicated, we're putting the patients through invasive and procedures, or putting pressure on resources where it's not indicated. And I assure you, if you're not sure and you send us a rego with a light chain, say of 100, and if we think this patient needs to be seen on a cancer pathway, we will reply back and say, please refer the patient on a 2-week wait. We've done that. I've done that this week myself. So I think not to initiate it in the first place, speak to us. And if we think it's necessary, we'll ask you to do so. So unpicking something's harder than starting it in the first place. Abs, you've got your hand up.
Yeah, I was just going to say thank you very much. I mean, I think it's really about getting the right people in the right service, just to make sure that, you know, we don't overwhelm the haematological service. And so, Lindsay, I can hear your concerns, but maybe we can take this offline. That'd be really helpful.
I'm muted, sorry, if we can move on to the next slide, please. So this is just some of the diagnostic criteria that we use. So in terms of what CRAB features are, the degree of anemia, the degree of renal impairment. I know these slides are going to be shared with you, so I'm not going to go into it with too much detail. If we go to the next slide, just for the interest of time, a lot of these patients will be diagnosed as an MGUS. So you can have quite chunky paraproteins and still be an MGUS. But of course, if they've got a paraprotein more than 10, we would be more than happy to see them on a cancer pathway or urgently in haematology if they are referred in. Next slide, please. And this is just a copy of the North West London outpatient pathways, which are available to you all in primary care. They just set out criteria, which helps you as GPs also just to sort of risk stratify how soon patients need to be seen or how alarmed you need to be with those results. And if you just go to the next slide, there's a little pathway here you can follow in terms of who requires a 2-week wait, routine, urgent, or advice and guidance review. Next slide. So I'm going to pass over to Anastasia now.
Okay, so sorry, I'm conscious we're running out of time. So again, this is a real referral, and this comes back to more of the vague symptoms. After Akila's talk, you should all be able to answer this really simply. So 73-year-old lady, ongoing bone pain, aches all over, persistent raised ESR, recent bloods show high Kappa light chain level with a Kappa to Lambda ratio of 1.92 and a raised IgG. Past medical history of osteoarthritis, hypertension, knee pain, glaucoma. So next slide, please. So bloods here, I'll give you a sec to have a look. Essentially normal full blood count, normal renal function and hematinics, elevated ESR, no paraprotein on your serum protein electrophoresis, polyclonal increase in your immunoglobulins, and a slightly high Kappa, but the ratio is actually not too high, not too far off. Okay, so again, quick poll, you should all be a bit more confident now. Any more offers? I've got 2 responses, 4, 5, excellent. Okay, brilliant. So if we go on to the next slide now, actually we can skip this slide. I think you all know about ESRs. So as Akila has said, raised polyimmunoglobulins. This has a very inflammatory, infective, autoimmune feel to it. The Kappa light chain is only mildly abnormal. It's unlikely to be significant. I'm wondering of more of a rheumatological issue. I would recommend checking vitamin D. We see so many people now who have vitamin Ds in single figures, and actually giving them a bit of vitamin D does sort them out. And is it related to her osteoarthritis? And this is a perfect case, as most of you have said, to refer to advice and guidance and repeat the bloods. But there's no evidence of malignancy here. Okay, so the next case, another 83-year-old man, platelet count has gone down slightly, macrocytic anemia, still getting night sweats. It has been 18 months ago that he stopped Zoladex. You have already seen him in August 2020 as he has MGUS, but a CT chest abdo-pelvis at this time was normal. Please could you advise? Okay, so he's got a history of prostate cancer, had radical radiotherapy and Zoladex, which has been stopped now for 2 years. He's got an IgG Lambda MGUS with a 15-gram paraprotein, so reasonable paraprotein, but a normal ratio. And he was seen by us 2 years ago, had a normal CT. He had drenching sweats at this time point, and the sweats are unchanged. So next slide. And this is the abnormal full blood count that he was referred with. So again, I'd just like to highlight that these abnormalities are really mild. This is really unlikely to be anything severe. Next slide. His paraprotein is unchanged. His serum free light chain ratio is still normal. His renal function is not changed. His calcium is still normal. Okay, next slide. So what would you do in this situation? Excellent. You can all come again. So he's got a new macrocytosis. He's got very mild changes in other things. He needs some hematinics. His night sweats haven't changed. If we can go on to the next slide. So night sweats by themselves are not a reason to refer. They have to be associated with something else. So you've not said he's got any new lymphadenopathy and hepatosplenomegaly. So night sweats by themselves have to come with something. Also remember, there are loads of causes for night sweats. So most likely this man's were triggered by Zoladex and they just haven't gotten better. And we do see that night sweats persist for several years, even after the initial hormonal insult is gone. So menopausal night sweats can persist for 20 plus years. We see. So if nothing clinically has changed, then offering this man another CT is unlikely to be of further benefit. The other vague symptoms that people refer for, things like pruritus. When you're referring pruritus, we've seen quite a few cases of bad eczema and other skin conditions. Just think a bit more logically. If they've got a normal full blood count, the usual cause of pruritus is going to be polycythemia. So if they've got a normal full blood count, it probably isn't hematological. Bone pain, as Akila said right at the beginning, it's got to be associated with an abnormal myeloma screen or full blood count. Fatigue, it's not just fatigue by itself, lots of causes for fatigue. Do they also have an abnormal full blood count? Are they anemic? Is that the cause of the fatigue? And a raised B12, again, like we said before, in the context of an abnormal full blood count. So for the next slide, so going back to this man, if he's had night sweats going on for 2 years and he had a clear precipitant a couple of years ago, he's not going to have a lymphoma, which hasn't got any other signs at this point. So consider your other causes, drugs, particularly antidepressants, anxiety, other infections, TB, menopause, obviously not for this gentleman, hypoglycemia. Okay, these are all far more common than your undiagnosed lymphomas that are going on for 2 years. His paraprotein is stable, his serum free light chains are not elevated, so don't suggest any progression. And the FBC is really only mildly abnormal. We see so many of these just mildly abnormal ones. Please just do use your common sense. Recheck, check your hematinics, and if you are concerned, then send it as an advice and guidance. Okay, next slide. Akila.
This brings us on to the last section, and that's the lymphoma section. So that's that completes the front page of the cancer suspected hematological pathway referral form. So the lymphoma section covers unexplained splenomegaly, persistent lymphadenopathy, or lymphadenopathy with B symptoms. So that's how it's changed. So historically, patients could be sent in with just B symptoms, so just night sweats or just pruritus or just weight loss. It now has to be coupled with lymphadenopathy to be met on the criteria to be seen as a 2-week wait. So just little things to consider, which often are already done before these patients come to us, is you often already have all of these blood tests done, so full blood count, ESR, USNEs, LFTs and LDH, and consider a paraprotein. Often these low-grade lymphomas can have a paraprotein associated with them. Night sweats in isolation with normal blood counts are do not meet the criteria to be seen in as a 2-week wait. And mild splenomegaly with normal counts and no red flag symptoms do not meet the criteria, do not need a 2-week wait, and we would see routinely or triage appropriately and see in clinic. Next slide, please. So these were supposed to sort of come up one by one, but that's fine. I can talk this through. So things to consider when referring with a lump. So these patients in Hillingdon, we would typically triage, if they come in as a suspected cancer, we triage them into our lump clinic. So the timing and the interval change and associated symptoms. So sudden onset, a lump that's just come up often will settle down. The most common thing is it will settle down. If it's been persistent, then that's something to consider. Think about other associated symptoms. Have they got an upper respiratory tract infection, other GI, any other symptoms that might localize that lymph node site? So upper symptoms or ear, nose, throat would be cervical, occipital, even some axillary or supraclavicular, and then groin nodes in terms of your GI symptoms. The COVID vaccine has led to a lot of axillary lymph nodes being referred to us, which by the time the patient comes, they've settled down. And then think about your clinical examination, and that is key. Where is the lymph node? What is its size? How does it feel? What is the overlying skin like? Is it fixed to it? Is there any skin changes around it? Are there any ENT symptoms? And weigh the patient, because it's really helpful for us if they come with a weight and then we see them even 2 weeks later and they've lost more weight, or whether they've got stable weight. Blood tests to be done would be things like a full blood count, looking for lymphocytosis, cytopenias, and maybe even requesting a blood film where we'd be looking for abnormal looking lymphoid cells. A raised LDH would be concerning, and hypercalcemia would be concerning. I would actually advocate that if you have a patient with a lump and you've done bloods and they've got a high calcium, you get us on the phone, because we might actually just say get the patient admitted via A&E. Hypercalcemia is a bad sign with lymphoma. It usually suggests an aggressive form of lymphoma, and we'd want to sort them out as an inpatient. B symptoms, so fever, weight loss, night sweats. Anastasia has already gone through the specific categorization. And red flag symptoms. So red flag symptoms with lumps, for example, lump in the neck, shortness of breath, plethoric appearance. We're worried about SVCO, so superior vena cava obstruction. Any signs of obstruction, bypass the cancer pathway referral, please send the patient straight to A&E, and we will pick the patient up from there. So, I mean, this is just in terms of if a patient calls you with a lump, it's important to get an examination done, and also just ask about chronicity and other comorbidities or other symptoms associated with it. Go to next slide, please. So in terms of the Northwest London outpatient pathway, this is just summarising what it says in terms of the referral criteria or what you need to consider before referring. Next slide, please. And that then brings us onto splenomegaly. More often than not, splenomegaly is an incidental finding for a scan a patient's had done for something else. It is one of those things, and I think sometimes you need to keep in mind how tall a patient is, because you can get variation, but we will see these patients, we will rescan them if need be and do the necessary blood tests as required. And if nothing more needs to be done, reassure and discharge back to yourselves. And then this is the Northwest London outpatient pathway in things to consider for splenomegaly. And very few of them turn out to be lymphoma. There are lots of other causes for it, but if we see them in clinic, we'll rule most of them out. Okay. So just in terms of sites of lymphadenopathy, is it isolated? So is it one group in the cervical, axillary, and inguinal, or is it generalized? Also assess the abdomen for hepatosplenomegaly, and it could be with or without B symptoms. So it's sometimes nice for us to know. It also helps us sort of categorize in terms of how sick this patient is. It's not been unheard of for us to just get on the phone to a patient and ask them to come straight to A&E when we've seen some 2-week waits. And I just think it's also our job to reassure yourselves as primary care physicians that downgrading a 2-week wait decision is not one that we take lightly, because we take responsibility for downgrading that. Okay, so we wouldn't be doing that as a light consideration, and often we speak to our colleagues and we all agree before we do this, and then it is something that we need to communicate to yourselves, and we need to be in agreement. If you point blank disagree, often through that conversation we realize that patient could be seen elsewhere more appropriately. So please be reassured that we're not here to try and discourage you from referring patients to us on a cancer pathway. It's just regarding appropriate referrals so that the patients have the best experience, and it's not something to be taken lightly for a patient to be told that you're being referred as a 2-week wait on a suspected cancer pathway. So if we just move on to the next slide. So these are just some quick cases. They're not going to be done through polls, but they were just cases that I had received on a 2-week wait pathway. The first one being a 27-year-old male referred to lump clinic with a neck lump. The next being who, when seen in clinic, had the adenopathy had completely gone. And on further questioning, the patient said maybe at the time actually had a bit of a cough, cold, maybe a bit of a strep throat, and it's gone now. So that was a reassure and discharge. The next is an 88-year-old female referred to lump clinic with a neck lump and fatigue. When the patient was seen in clinic, she walked in incredibly kyphotic. So literally she was looking at the floor, and the neck lump was actually a palpable spinal process at the base of her neck. So she was just simply reassured and discharged. And the last one was a 41-year-old female referred to a lump clinic with neck and axillary swellings. and they had a severe dermatopathy, probably one of the worst contact dermatitis or eczema in an adult that I've ever seen, but with associated generalized adenopathy, and that resulted in an urgent referral to in-house to dermatology, and the patient was reviewed and managed appropriately. Just regarding lump referrals to the on the cancer pathway, very rarely do we downgrade or reject these, because obviously they need to be physically seen by ourselves, and if you feel you've seen a patient with a lump that needs to be seen, we will do so. It's more the ones which are clear cut with this looks like an MGUS or this looks polyclonal are the ones that we would downgrade or not see. We can move on. So I don't know who's doing these bits. So this is just a resource regarding I know you're very time poor and very guideline heavy. We know this and we do appreciate this. But if there's one guideline in haematology we could signpost you to, it's the Northwest London Haematology Referral Guidelines. They're excellent, and the way they've been set out is you don't have to trawl through the entire guideline electronically. You can just go to the bit that you want. So if it's lymphocytosis and you're not sure, you can click on lymphocytosis and look for what you need to address before referring in. Next slide, please. So these are some nice resources. I don't know whose bit I'm taking now.
Thanks, Cll. Thank you very much. So yeah, these are some great resources. Please have a look through at your own leisure. I guess I want to just kind of close and say thank you so much to our haematology colleagues. These kind of webinars within haematology, I learned so much. So I can say we went through so much here. A few things that I've picked up on, and I think we should all just remember, is the definition of a highly abnormal blood count and when to refer in. Think about your red flag haematological symptoms, and those that are just a little bit borderline and think out of the box. This is not necessarily haematological cancers. Do your hematinics, think about the history, examine the patients. If you're not sure, advice and guidance is always there. Remember what was said by our colleagues, that bleeding within patients with a platelet count over 50 is highly unusual, so no need to worry there. And if more than one cell type is actually affected within the full blood count, then bone marrow suppression is more likely, infiltration is more likely rather than reactive. We talked about B12s, we talked about hematinics, and we talked about all the different CLL presentations where the slightly more low-risk patients versus slightly more high-risk patients, and when to send these people appropriately to haematology and the consequences of that. We moved on to myeloma, and we broke things down really nicely because we were able to think about the changes to the Panel London referral form and thinking about the real importance about what is a monoclonal versus polyclonal. Think about your paraprotein levels, what is the actual threshold, and look at the serum free light chain ratio. And what does that mean? Is this a hematological malignancy, or is this slight changes, not hematological, but a reflection of some kind of systemic illness that we need to think about something else? Think about what we can do in primary care. Think about MGUS. We talked about vague symptoms, and we talked about how many different things out there. I mean, I lead the vague symptom pathway as well at Chell West, and you can think about all the different other things that vague symptoms can cause, and not just cancer, and certainly not just hematological malignancies. But please have that at the back of your mind. Thank you for going through the lymphoma bits, and thank you for referencing the Northwest London referral criteria and your approach to lumps and bumps and splenomegaly. So much volume there. I'm going to go back and digest that, and we're going to circulate this through for everybody else and all our colleagues out there that couldn't make it today. So just once again, I just want to thank you so much for coming, Cll and Anastasia. And if there are any other questions,
please ask now.
Please
just
do.
To say, I have posted the link to the Northwest London guidelines. Add it to your favourites. Have it there, ready to go. It helps with interpreting loads of blood results that aren't even to do with hematology. So just add it to your favourites, genuinely.
Really good idea. Lots of positive feedback within the chat. Great. Okay, and excellent that we finished right on time. So thank you, everybody, and I'll let everybody get back to their clinical duties. And we are going to post the feedback. Sophie, if you could kindly just put that in the chat box. You've done it already. If everyone could just click on that, and that will help us kind of shape future webinars. Thanks very much, everyone.